Morning, everyone. I'll be starting topic Muddles on behalf of Medicine Fair. So I'll be presenting two case scenarios. So starting with case one, Mr. X, 17 years old from Tiruvannamalai, presented with giddiness since 1 week and imbalance while walking since 1 week. While working in his farm at around 10 a.m., he developed sudden onset vertiginous sensation associated with occipital headache, following which he had loss of consciousness. He regained consciousness after 5 minutes. He was immediately taken to local hospital where his BP pressure was 270/100. There was history of difficulty in balancing following that event and history of swaying backwards while sitting. There was no history of any smearing of food, no history of any cranial nerve deficit, motor weakness of upper lower limbs, sensory disturbances, or bladder or bowel involvement. There was no history of any diplopia, visual blurring, hearing loss, or nasal regurgitation. Personal history is known case of hypertension since 10 years, not regular on medication. No family history of malignant for TB. Examination by his vitals, by the time he presented here, his BP was 150/90. Other vitals were normal. His cerebellar signs, he had horizontal nystagmus towards the right side. And other positive signs was while sitting, he was swaying back and gait and stance was wide, with Romberg's positive. However, there was no dysdiagokinesia, no normal finger to nose testing, no dysmetria, no titubation. Heel shin test was also negative. His other CNS examination was normal. So coming to this case two, Mr. White, 62 years old, from Vellore, presented with 1 episode of seizure, imbalance while walking since 1 week and swaying on right side. He had this event following the 1 episode of GTCS, which involved upholding of eyes, tonic-clonic movements of all four limbs lasting for 1 minute with post-ictal confusion. Following that, he developed difficulty in balancing while walking and smearing of food on face and swaying on the right side. However, there is no other history of any cranial deficit or motor weakness or sensory disturbances. There is no history of bowel or bladder involvement, no history of diplopia, visual blurring, hearing loss, or nasal regurgitation. Known case of hypertension since 5 years, with a past history of CV on July 2020, which he had left hemiparesis with facial nerve palsy. So coming to his clinical examination, his cerebellar signs was was positive on the right side. The dysmetria on the right, finger nose test on positive on the right, dysdiagokinesia positive on the right, heel shin on the right side, and however he also had a wide stance gait, wide gait, and Romberg's swaying to the right. Apart from that, there was no nystagmus or no titubation. Other CNS examination was normal. So both these cases, anyone wants to localize the first case in which he had just imbalance on sitting and swaying backwards with a right-sided horizontal nystagmus with no involvement of any motor, sensory, or bowel bladder. Second case is involvement right-sided ataxic symptoms. Localization, we'll localize to cerebellum, and now I'll be talking about the localization of cerebellum. I just summarize the case. So first case is Mr. X with giddiness and imbalance with occipital headache, with no other signs of any higher mental functions or no involvement of cranial nerves, motors, or sensory or whatnot. Second case is imbalance and swaying with to the right and positive right limb ataxia without involvement of any other. So today I will be discussing about localization of cerebellar disease. So anatomically we can classify it to anterior, posterior, and flocculonodular lobe, shown in the figure. And so the function classification is the middlemost part is the spinocerebellum, which is mostly involved in the truncal ataxia. However, the cerebral hemispheres are mostly involved in the limb ataxias, associated limb ataxias. And so we have so it's divided into pilocerebellum, neocerebellum, and vestibulocerebellum. So the control of skilled movements is by the paravermian area. The control of the posture is by the vermian area, and control of the balance and eye movements is by the vestibular flocculonodular lobe, right, which is the vestibulocerebellum. So this is a somatotropic diagram of the somatotropic diagram in the cerebellum, in which the trunk, neck and trunk lies in the vermis. However, the limbs lie in the paravermian area. So accordingly, whenever there is a pathology, there will be a involvement ataxia of the corresponding limb. So this is the representation of the nuclei with the functions. So coming from the lateral to the medial starts the dentate nucleus present in the cerebellar hemisphere, which is involved in the motor planning. And however, the Vermian and the paravermian area is during the motor execution. So this is the blood supply of the cerebellum, which in the superior part supplied by the superior cerebellar artery, the inferior and the posterior part by the posterior retrocerebellar artery. So now coming to the cerebellum. So as I mentioned, the somatotropic representation, the head and neck and trunk lies in the vermis in the centrum, and the paravermian area represents the limbs. So the vermis part again, you have the, as I mentioned that. So any pathology in the vermis or the paravermis area, you will have the truncal ataxia. There will be body disequilibrium, gait ataxia, cadnum gait will be difficult. There will be tendency to fall back or front. Unlike in the cerebellar hemisphere, in which the ipsilateral involvement, there will be tendency to fall on that side. However, there won't be any titubation or other signs are titubation, ocular dysmetria, upbeat nystagmus, which is more unlike in cerebellum, cerebellar hemisphere, you will have a horizontal nystagmus. So coming to the cerebellar hemisphere, they will have disturbances of skilled movement, limb ataxia, dysmetria, dyssynergia, dysdiagokinesia, hypotonicity, and there will be nystagmus which is more horizontal than rotatory. However, in the vermis, it is more of a upbeat nystagmus. And they will also dysfunction the finger to finger test or finger nose. And so the fastigian nucleus which is involved in the vermis is usually, if there is pathology, there will be abnormality during the movement. However, when you plan for the movement, if there is a pathology, it will be abnormal. So coming to the gloculonodular lobe, so usually it is involved in the if it is involved, then the patient will have vertigo, ataxia, and difficulty in maintaining steady head position and visual fixation. So, however, we have to note that in case of a vermis involvement, we should always look for signs of there will be signs of obstruction, hydrocephalus, which can present as headache or papilledema. So first, we need to differentiate between a cerebellar ataxia and sensory ataxia. Cerebellar, during finger nose testing, there will be intentional tremor. However, sensory ataxia is described as a surging or meandering movement, which worsens with closed eyes. Accompanying features with cerebellar ataxia, they will have nystagmus and dysarthria. However, sensory ataxia, they will have decreased proprioception, rhomboid sign. Gait will be wide based on both the cerebellar and sensory ataxia. After localization, going to etiology, so they can it can be acute, subacute, or chronic. Acute in case of intoxication, alcohol, lithium, phenytoin. Acute viral cerebellitis, post-infection syndrome. Subacute, cytotoxic chemotherapy drugs, alcohol, B12, B1 deficiency, Lyme disease, and chronic in case of paraneoplastic syndrome, anti-gliadin antibody, hypothyroidism, syphilis, tabes dorsalis, phenytoin toxicity, and you get this focal and ipsilateral cerebellar signs. In again, we can divide to acute, subacute, and chronic. Acute in case of vascular event, which our patient had, infectious in case of cerebellar abscesses. Subacute from days to weeks will be neoplastic, demyelinating disease, multiple sclerosis, or age-related multifocal leukoencephalopathy. And chronic in case of congenital lesions or a stable gliosis second to vascular lesion or a demyelinating plaque. So coming to case one, first patient had just a truncal ataxia with no limb ataxia. There was no even cerebellar signs was negative for dysdiagokinesia or finger to nose test, and there was tendency to fall backward with a horizontal nystagmus towards the right. Vertiginous sensation at the onset, which was acute in onset. So now coming to this first case, where do we localize? So this is majorly predominantly a truncal weakness, which is actually localized to a. So we did an MRI which showed a lesion in the paravermian area, and so clinically it localized to a paravermian more than a vermis area. So the MRI reported as a hematomas in right cerebellar hemisphere, lateral to vermis with mild mass effect, but no significant effacement of the fourth ventricle. This patient didn't have any obstructive signs of any papilledema or headache. Case 2 presented with a limb ataxia with a truncal and limb ataxia with right-sided cerebellar signs positive and with involvement with swaying on the right side. So it is more of an appendicular ataxia. So again, it will be localizing to the cerebellar hemisphere, and whichever limb is ataxic, ipsilateral hemisphere will be involved. So the localizing right cerebellar hemisphere. However, since there is truncal ataxia also, Burmese also was involved. So MRI brain showed a restricted diffusion with corresponding flare. Hyperintensity noted in right cerebellar hemisphere with right only, minimally extending to posterior aspect of right hemisphere. However, there were no other cranial abnormalities. 6.7 normal. So this patient, since when had an attenuation of vessels with large vessel atherosclerosis, started on DAPT and statins. And the previous one was a hemorrhagic stroke. It was in the paravermin area, but in the blood pressure was controlled, target BP of 140 by 90, and antihypertension was optimized and lower. So my learning points are localization of cerebellar disease, anatomical and functional classification.
Thank you, Dr. Osborn, for the presentation. Are there any questions, Dr. Osborn? There's one question, like how do you check for Romberg's in this patient? You mentioned Romberg's is negative or Romberg's is.
So you can test that by closing eyes. You will sway on if there is ipsilateral hemisphere involvement on that side. If it's swinging frontal or backwards, that is more towards the Burmese.
Romberg's, as I know, is mostly a function of sensory ataxia. Because your patient will not even, when you hear impacts, when standing up, not even able to walk and all that. So to make him stand up and close the eyes and check Romberg's, I think it will be difficult now. That's what I thought. Any other questions? If not, we move on to the next presentation.